Margaret Preston, president of Power Over Parkinsons, and today, in conjunction with our Pop Profile series, we have Dr. Catherine Crenshaw, neuropsychologist and the director of the Perioperative Cognitive Anesthesia Network, or the PeCAN, at the University of Florida College of Public Health and Health Profession within the College of Medicine. So, Dr. Crenshaw, I can't thank you enough for being here, sharing your work, and letting us into your world a little bit.
Well, thank you so much for the invitation. I really appreciate it.
It's
yes, thank you so much. Yes.
So I'd like to jump into the postoperative cognitive complications that can happen as a result of surgery. So starting at more of a general high level, and then we'll get into some of that risk mitigation and what can be done within the healthcare industry to kind of mitigate what can happen after surgery. And really starting at a bird's eye view, we know cases of Parkinson's and neurological disorders are on the rise, of course, Alzheimer's. It will only increase. And of course, this is really going to put a burden, immense burden potentially on the healthcare system as these post-operative cognitive complications and challenges arise. So your work really focuses on identifying those gaps in care for older adults who elect surgery with anesthesia. So take a few minutes, share with our listeners what gaps you are finding.
Sure. Oh, thank you so much for the great question. Well, first of all, hospitals are routinely providing increased surgical services, and they want to improve, optimize health care for everybody, but particularly for as we get older, we want to have improved quality of life. So there's increased number of surgeries. Individuals who are older are electing the most surgeries. About 50% of the surgeries are done on individuals age 65 and older. And so one of the big issues that we realize is that researchers have realized this since about 1950, that as we get older, we become more vulnerable and sensitive to anesthetic and surgical stressors. Most of the studies that have been done following individuals longitudinally from pre-surgery to post-surgery have been done on people who are typically, quote unquote, cognitively well, right? And of those studies that have been done, what they've shown is that if you go through a surgery like a knee replacement surgery or a shoulder surgery, everybody, regardless of age, about 40% of individuals after a surgery, when they go home, 40% of individuals, regardless of their age, can experience a change in their memory or attention. About 2 standard deviations decline in their memory and attention. That lingers, though, for people who are older. So if you're 65 and older, typically about 15% of individuals at 3 months after surgery will still have some lingering attention and memory issues. And then that eventually subsides out to 1 year, about 1 to 3% of individuals. Those studies have been done on cognitively well adults. The problem is that it's really very challenging to do prospective longitudinal follows on people who have a neurodegenerative disorder like Parkinson's disease. A lot of times individuals with Parkinson's disease, they may choose and then they need a knee or a hip or a shoulder replacement, but they don't typically tell their primary care physician, or they don't tell their neurologist that they're having that surgery. And they fall through the cracks. And researchers really don't pay a lot of attention with aggressively trying to follow individuals with Parkinson's disease pre and post-operatively. And so that's an issue. They are particularly vulnerable just due to the neurodegenerative disorder itself and the change in dopamine and how they associate with acetylcholine. What we know is that from retrospective studies that have been done through Medicare review and large hospital studies across the nation, this is all looking at retrospective data, that individuals with Parkinson's disease are particularly vulnerable to those medications and stressors. So we are, in general, clinicians and researchers who study neurodegenerative and neurological function are particularly concerned about individuals with Parkinson's having cognitive issues after elective surgeries.
That makes sense. And I suspect it's probably hard to follow those with neurodegenerative diseases because they're, as you're following them, determining what's surgical related versus just disease progression as well is probably a challenge you all face.
It is. It's really, and that you need to have individuals who have Parkinson's disease who don't have the surgeries.
Right.
To be able to follow them at the same time as individuals who are having the surgeries so that you can see how people change with the election of the surgery procedure. So there's a whole host of issues.
I can imagine. Yeah. Well, staying at this high level, can you share what the impact of these gaps are on older adults undergoing surgery with anesthesia? In other words, what are the complications? Probably depression, delirium, maybe unachieved surgical goals. Share with some of the things that could go wrong.
Yeah, well, there are a lot of things that can go right. So for example, if somebody with Parkinson's needs to have a shoulder replacement or a knee to improve their functioning, there are a lot of positive things, but there are some things just to be sensitive to, right? So like you mentioned, there can be associated changes in sleep-wake cycle that can happen when you go through a surgery procedure. There can be, and that sleep-wake cycle change, meaning they may not sleep as well because of pain levels, and that can disrupt your mood. It can also disrupt how well you're learning new information. And individuals with Parkinson's disease can also have difficulties typically with speed of thought. So pulling up words, all those aspects can get a little more challenging after surgery if they're taking pain medication, if they have pain, if their sleep is altered. So there are certain elements to be aware of as individuals elect to go through a surgery procedure, that there can be some changes.
That makes sense.
Yeah. And one of the major ones that we really worry about is called delirium. Delirium is that confusion that can happen. It can happen if you have an infection, if you have a urinary tract infection, you can have delirium, where there's an alteration in some sort of biological element that's resulting in an altered mental status for that individual. And they can become confused, they can become more lethargic, and they can become agitated. But after surgery, there are certain medications that will be given to help with pain monitoring, or to help with nausea, alleviate nausea, and that actually can elicit more confusion for individuals. And individuals with Parkinson's disease appear to be particularly prone to that.
Right.
And to developing confusion after surgery, and that's called postoperative delirium. Another big hole in a gap for individuals with Parkinson's disease is the control and the consideration of their medications around the time of surgery. Anesthesiologists and surgeons are particularly, sometimes they're very hesitant to do surgeries on individuals with Parkinson's disease, primarily because they know that they have their dopamine and their regulation can be very sensitive to the medications that they give around the time of surgery. So they may be hesitant to do a surgery, which is good. That means they are considering the needs of the patient.
Right.
But along with that, sometimes the anesthesiologist and the team members really don't appreciate how levodopa or the medication needs to be administered on a very routine basis because of its half-life. Its half-life is pretty short.
Right. So
there are certain rules, guidelines to consider for the surgery team. And so that's a whole, there's limited education provided to anesthesiologists and surgeons about neurodegenerative disorders and their reaction to medications. And it's not their fault.
Right.
It's primarily because it's just, there's a lot we don't know. So the patient has to be a really good and strong advocate for themselves.
That's right. You kind of dovetailed into my next question perfectly as we talked about this perioperative environment really being a stress test. Involves so many stressors, like you talked about, new medications, sleep disruptions, pain. While this description is very accurate and something, that really casts a light on what could happen with these surgeries, it's somewhat novel, as we look to the work that's being done. I think a lot of times the brain isn't considered a vital organ within the surgical realm. So
Yeah.
share stress and share why the brain really should be in that preoperative cognitive assessment really should be part of the perioperative measures.
Yeah, well, that's a great question. Well, we say that, you know, anesthesiologists and surgeons will send for a cardiac assessment or a consult, a clearance for individuals who might have any issues with diabetes, or if they have atrial fibrillation, they'll say, oh, let's get a cardiac clearance before you have your surgery.
Right.
I have the mindset that we need to have brain or neuro clearance, right? And we like the idea of getting at least some sort of brain wellness snapshot for everybody who is particularly vulnerable individuals before they go through a surgery. So particularly for individuals who have Parkinson's disease, we think that it's really vital to at least get some sort of brain assessment, okay, at a baseline level, and some input to the providers, the surgery providers, about how that person is doing and the special needs of that individual. Because you're, like you said, the brain really is it's a vital organ. It is who we are. It is the organ that helps us for our thinking. It's the organ that produces our thinking and our memory. It is the organ that is directly responsive to the anesthetic, all the medications. The frontal lobe of our brain, and there's a middle structure in the brain called the thalamus. Those are immediately impacted by anesthetics and any pain level medications. And our electrical activity changes and gets slower when we get sleepy. It gets slower when we have any type of cognitive issue, or Parkinson's disease. They'll have a different brainwave pattern.
Right.
So they will, individuals with Parkinson's disease or Alzheimer's disease, multiple sclerosis, they have a different brain than individuals who don't have those aspects. So they respond differently.
So these perioperative measures, as we talked about, having some sort of baseline, almost a snapshot, as you mentioned, will take a lot of communication and a lot of connectivity between providers. So I'd like to kind of move into some of our kind of proposed action plans. What can be done at this point? We've kind of addressed what we're looking at and what actions can be done. So as we look to risk mitigation, with a lot of work that can be done pre-surgery, share and elaborate on preoperative identification for cognitive impairment and other processes that could be in place within the care system. So in other words, I had mentioned PeCAN, that you're the director of at the University of Florida. Other universities, such as Duke University, has this discipline in place, or this program in place. So how can this be really part of become a pre-surgical evaluation, and how can we get that snapshot in pre-surgery?
Okay, that's a great question. Well, there are different ways to do it. So here in the we have what's called Perioperative Cognitive Anesthesia Network, PeCAN. And what we do here is, you can, when you come in for your pre-surgery appointment, you can get a cognitive screener, which is very short, takes about 5 minutes. And that's something that your nurse or your physician can do. There are different ones you can do. There's like a mini mental state exam, there's a clock drawing, there's a mini cog. There are different tests that you can get from your primary. If a person flags as having some issues, or they're concerned about their memory, at least here at the University of Florida, what happens, then they get referred to see me or another provider. And we will do an evaluation we'll meet for 90 minutes to do a more in-depth cognitive review, history, and we will write recommendations. We put a note in the chart, and that chart report is routed to the surgeon and the anesthesia provider. And then we get feedback to the patient, and then we follow up with them after the surgery to check and see how they're doing. So that's what we do here. You mentioned Duke's program. That's a fabulous program too. That's called POSH. And that program is run by geriatricians who also do it. Our team here has neuropsychology, and then we have geriatricians and behavioral neurologists. So they both have different they're just different ways to do it. Now, if you don't have access to those programs, one thing to do is to make sure that you are telling your neurologist that you're having a surgery procedure, and also to ideally have that neurologist talk to the anesthesiologist and the surgery team about any special needs that you may have, particularly with regard to your medications.
That makes sense.
That's an important thing. You can also ask your neurologist to send over a report, or at least a cognitive check on you, to do one of those short evals on you, like the mini cog, or there's different ones that they'll know how to do it. You just ask them, I'd like to get a brain wellness or a cognitive screening with you here in my appointment with you, Dr. whoever your neurologist is, and please send that over to my surgery team so that they know how I'm doing. That's something you can do. You can also just really have a nice, intense conversation with your anesthesiologist and your surgeon about your concerns. And make sure that you're also sharing information about all of your medications you're taking, and the importance that you stay consistent with your medications pre and post-operatively.
What I'm hearing a lot, and you had noted previous in our conversation, is really being your own advocate, kind of speaking up and helping navigate. If you're potentially not at a Duke University or University of Florida, kind of being your own advocate and talking among your providers about what you're taking, what you're doing,
Yes.
how you feel today versus post-operative. So it sounds like something that I think our listeners will definitely be able to take away is you often have to kind of be your own advocate and speak up and communicate.
Yes. There's also a very wonderful hospital kit that you get through the National Parkinson's Foundation or the Parkinson Foundation. They have a hospital kit that you can take that they'll give to you for free. I encourage everybody to sign up for that.
Absolutely.
Yeah.
I think, as we look, again, we're getting a little bit more specific in reference of your literature. You place an emphasis on the role of neuropsychologist and how this specialist can really positively impact surgical outcomes. So for our listeners who are unfamiliar with neuropsychologist as a very specific discipline, take a few minutes and share more about this area and how a neuropsychologist can really intervene within the brain behavior standpoint as we look at surgery.
Oh, it's great. So if you don't know what a neuropsychologist is, you're not alone. So a neuropsychologist.
Most people know the second half of the word, right? But combined, they're not quite sure.
We're brain behavior specialists. So we are individuals. We are a clinical psychologist. We have a doctorate degree, PhD. What happens for us is that we get through our doctorate program. After we have finished our doctorate program, we do a residency, and then, or an internship, whatever term you want to use. And then we do 2 years of additional fellowship training to get our licensure. And then we get board certified after that. And so for that, we have specialists in how to understand behaviors and how those relate to different areas of the brain. We know how to do assessments. We appreciate medication considerations, and we deal also with psychological aspects and how those interact with cognition and pain and all those various things. So that's one of the aspects about being a neuropsychologist. And for us, we pay particularly attention in the perioperative world, specifically, appreciating, does an individual have any cognitive issues that may make them particularly prone to risk for certain events that can happen within the perioperative setting. We can also help with identifying if there are any behaviors that could be tailored a bit to help improve cognition before a surgery procedure. Some things just can be sleep. We can help with, there are some behavioral strategies that you can do to help with pain management, depression. We help with diagnoses of these elements. We can make referrals. It's interesting. We're a breed of professionals who are in between different, I guess you'd say, different arenas, and we help to connect patients to different different professions, right?
Yeah.
So I can make referrals to neurology, to primary care. I can talk to anesthesiologists. Our job is just to know a little bit about every single discipline, but to reflect it back to that person's brain.
Okay, that's really interesting. The part about, certainly being the connector or intermediary between the patient and another doctor or specialist. Also, you had mentioned, I think some almost pre-surgical therapy my mind had not gone in that direction yet after reading your work, and that really touched me, and I hope it touches the listeners in terms of things that can be done, tangible things that can be done pre-surgery. Changing behavior and in preparation for surgery.
Oh yeah, there's definitely some things.
Yeah,
one thing you want to think about is we talk to patients a lot about improving inflammation, right? So, well, think about somebody who has diabetes and who has a cut, right? An individual who has uncontrolled diabetes is not going to respond that well to a cut or an injury, right? If you compare that person to somebody who doesn't have diabetes, right? There's going to be a difference in the healing process for that individual who has diabetes, right?
Sure.
But they have chronic inflammation, bodily inflammation, if you have diabetes, right? So if you had that person with diabetes and they go through a surgery procedure, you can see how they're chronically inflamed. They may not be able to have that healing process that's necessary to just recover quicker after the surgical procedure. So one of the considerations is, it's if a person can improve their body as best as possible before the surgery by reducing chronic inflammation. So that means improving your sleep, right? We want people before they have surgery to see what they can do to make sure that they're getting good night's sleep.
Sure.
We want to help with make sure that they're eating good foods, right? Stay away from white foods like sugar and bread, beers, things like that can cause inflammation. Alcohol, those cause inflammation. So you want to prehab is a word. You probably haven't heard of it, but prehabilitation is where you're optimizing your body so that when you go through this stress test, it will heal quicker, right? Yeah. So there are different things you can do.
Yeah. No, that's fascinating, and definitely something I think our listeners can noodle on and kind of take into consideration in their worlds if they're looking at a surgery in their future. So thank you for sharing that. Talking about pre and post surgical assessments and really comparison tools, if we can kind of delve into that. As we talked today, many pre-surgical older adult patients don't have a recent cognitive assessment tucked away in their medical file. We wish they do, and I'm sure you do as a neuropsychologist. We wish they do. But with this being said, surgical teams are charged with really conducting the due diligence on the patient's cognitive behaviors. Share with our listeners some of the methods surgical teams can utilize to obtain that general overview, that snapshot of the patient's cognitive health, and how these methods can then be compared to post-surgical scores.
You can ask your anesthesiology or your team provider to make sure that they're giving you a short delirium screener, at least after surgery. Those are some things that you can, there's one that's called the confusion assessment method. It is a short abbreviated, they're all different versions. It was created by Sharon Inouye and her team, very talented group. And these are tools that anesthesiologists are aware of, and many individuals in the hospital, and particularly nursing. And so they can acquire that. So you're looking if there are things specifically that the surgery team would like to do, that you would like the surgery team to do?
Yeah, what could they do to really obtain a quick overview or a snapshot of that cognitive health and then be able to compare it to the scores post-surgery?
Yeah, I would say that that would be a good one. That would be
Mhm.
doing the delirium screener. And then if you're with your family, they can also just make sure that they're monitoring you too. If you have a family member nearby or a friend,
Sure.
that's probably one of the best things, is to make sure that you have somebody who knows you really well, who's with you during the surgery process.
Mhm.
Because unfortunately, when we get into a hospital, there are, unless there's an ingrained pathway for getting pre and post-operative cognitive checks or brain wellness checks,
Mhm.
it's a little challenging if you're in a community hospital, right? And
Right.
they're not, they don't have that training, just because they
Sure.
don't have an academic medical center and it's not ingrained in every hospital now. But if you're in a community setting, and you're going to be moving from nurse to nurse and different surgeons, et cetera, or different people coming into the hospital room, the best thing you can do is to have somebody who knows you,
Mhm.
and can say, okay, this is atypical. This,
Right.
she or he is not the same as they were before having the surgery procedure.
Right.
Somebody who can be your advocate
Mhm.
after the surgery procedure and in your room if you have to spend the night at the hospital.
Mhm.
And when you go home, make sure that you have someone who is with you at home. That's
Mhm.
really important, who can watch you and report if there's something atypical.
Mhm.
That's the most important thing.
A follow-up question to this is not meant to be a curveball whatsoever, but I think about emergency surgery. So let's
Yeah.
say an appendix or whatever might happen to an aging individual. What would be your recommendation as far as kind of getting into the hospital unexpectedly? What should be shared in a hasty way? But of course, I have Parkinson's potentially. Here are my medications. What are a couple things that could be shared in more of a hasteful way?
Well, I would make sure that you have a package available like that, the Parkinson's Foundation
Mhm.
package that you can
Mhm.
have available, that has all of your medications, like you said, documentation of who your neurologist is. If you have a DBS, if a deep brain stimulator, have all that information available,
Sure.
and have that readily available to give to the team in the emergency department.
Mhm.
Also, ideally, have somebody there who's able to converse with the emergency department with regard to any changes in mental status that could have happened. I would say that those are the key aspects.
Yeah,
Yeah.
absolutely.
Yeah.
My mind is going off on and thinking about how one with Parkinson's, or really an aging person, could almost have something prepared at home in the event
Yes.
this could happen. And we talked about the Parkinson's Foundation kit, which is so helpful. Maybe we've got within that the medications we take
Yep.
in. If we've had DBS, the data that and
Yep.
the device. So I'm almost thinking of a preparation kit.
Yes.
But I'm sure
Definitely.
there's higher beings that are probably already addressing that as we speak. But my mind was
No,
immediately
you're right.
thinking of a packet almost to be able to grab.
Yep. I would have your packet ready. I
Yeah.
completely agree. I think everybody needs to have a packet, and they actually have them like that. I think they look like they're a little suitcase.
Yeah.
You
Yeah.
have
All the
available. Yeah.
notes. All the
Right.
notes.
Yeah. And make sure you take your meds. So
Mhm.
when you leave, you take your meds and you have your packet.
That's a good point. Absolutely.
Yep,
As
definitely.
I was going to say, I won't take too much of your time up, but as we begin to really wrap up this conversation, what advice would you give to patients with Parkinson's who are considering non-elective surgery, but are certainly apprehensive, understandably, about the effects of anesthesia?
Yeah. Well, if you're having an issue with quality of life, right, because you're having limited mobility or there's some issue that you need to address from a health wise, and it needs a surgical procedure, don't shy away from it because you're afraid of the anesthesia,
Right.
honestly, right?
Mhm.
You just do a lot of education and reach out to your neurologist, reach out to the surgeons, shop around. You are the consumer.
Mhm.
You find the person that you feel comfortable with from the surgery and talk to the anesthesiologist. There are all different ways to administer anesthesia, and there are new approaches that are developed to help reduce different medications that are now being used in anesthesia to help reduce postoperative nausea, to help reduce confusion. So please don't shy away from it if it's something that you need.
Okay.
That's probably the best thing I can say.
Yeah, that's great advice, because I think quality of life, as certainly as we talk with Parkinson's, but just holistically is really a good determinant of how to proceed.
Yeah, and I think if you are conscious about your medications and you have a good team, then more likely of having a very positive outcome than a negative one. Yeah.
Well, as we talked about, there is a lot of work to be done to incorporate patient cognitive health screenings into the pre-surgical world, and really creating this assessment in terms of kind of thinking about anesthetic dosage and really the general surgical plan. And I'd like to note the United Nations, the United Nations General Assembly calling 2021 to 2031 the decade of healthy aging. So this topic is hopefully forefront on the world stage. So share with our listeners what steps need to be made so we can incorporate some of these perioperative assessments into everyday surgical practice.
Oh, it's so great. I love that question. I would encourage your everybody if you get a chance to watch this, to request, and you talk to your primary about the need to do brain wellness checks. And I would just encourage everybody to stay open to it. Talk to the AARP, talk to the Parkinson's Foundation, ask for advocacy for appreciation for cognition in hospitalization, ask for advocacy about delirium checks in the hospital. That's the best thing you can do, is just advocate for the topic and advocate for yourself.
I agree.
Yeah.
I absolutely agree. Well, as we summarize, where can our listeners go to find more about you and your research and what you're working on, and how to really get involved in perioperative cognitive medicine studies and research?
Great. Well, thanks. So, for us, we have a website. You just type in UF, University of Florida Health, UF Health, and PeCAN, like the nut, PeCAN, easy to remember, and you should be able to find some information on us. We have lots of papers and various things you can look up. So we have a clinic, and then we also have research investigations. There are different research investigations going on wherever you are. But with us, we're doing studies right now where we're looking at individuals and how brains change for individuals with Parkinson's disease around the time of having a colonoscopy. So we're looking for people who are interested in studies like that. We're doing pre and post colonoscopy brain scans. But I would also look at NIH websites, but really go back to the Parkinson's Foundation also, and see what kind of studies that are being done there. You can always reach out to me as well.
Perfect.
Yeah.
Well, Dr. Crenshaw, I can't thank you enough for your time and sharing your world and your important work that you're doing. And thank you for sharing it with Power Over Parkinson's.
Thank you very much for the opportunity and for providing this really valuable resource for people.
It's my pleasure.
Thank you so much. Really lovely.
Thank you.
Thank you so much.